are MSM, who on the down low, wife has no idea, child's been born and diagnosed with HIV. And we have had to mandate and get legal protections for the child, where an officer of the law accompanies a nurse who will go to the house daily to give the child their medication, the infant and then baby, the medication, because the father refuses to let that happen. And it is all about the shame of even admitting who we are as a people, whether gay or bi, or have on occasion gone there, the fact that they are infected. And these same men many times don't even take their own medication because as far as they're concerned, they're living on borrowed time, and they're so ashamed of themselves for what they've done to themselves and to the child. So it is a multi-layered thing of shame that often leads us to even look at this drug as an option, because we want high self-esteem. We want to be the prettiest one in the room. We want to think that we have the biggest penis, the most beautiful ass. And then we want to just relax and enjoy sex. And meth also facilitates you getting some very handsome new people that maybe you wouldn't have access to, as long as you're the one that's providing the drug. So there's a lot of reasons why this is devastating our community, but it will continue to get worse before it gets any better. And you would be blown away by my PowerPoint if you could even see it. But I will do this and show you this image, because we created these two flyers. They're posters, excuse me. They're available in English and Spanish. And basically, they just spark the conversation about, are you partying and playing? And encourages people to go ahead and tell the testing counselor. If you put these in your testing room, it'll at least start the conversation and let people know that the testing counselor is trained and that they're user-friendly to the subject, so that they can at least look at more aggressively getting you on PrEP if you resist. So available in English and Spanish, free of charge on the website, poderosos.org. And hopefully there'll be Q&A afterwards, but I'm gonna go ahead and stop now. And I'm so sorry I wasn't able to get the PowerPoint to work, but we can make it available afterwards to anybody who sends us their email. And you can do that to Lopez at poderosos.org.
Thank you very much, Oscar, to share the information with us about this very important issue. This crystal meth is ravaging the gay community in every part of the country. We've seen that a lot here in New York as well. So again, you can make questions to Oscar about this topic at the end of the presentation, and we're going to go ahead and Allan, clear, you can go ahead now.
Hello, everyone. I'm honored to be here today. You can hear me okay? Yeah. So my name is Allan Clear. I'm the director of the Office of Drug User Health within the AIDS Institute at the New York State Department of Health. And hang on, sorry. Why is this not going forward? I'm back. Let's go here. That's better, I think. All right, let's see. Oh, there we go. So there we go. So this is where we're located. So we're an office within the AIDS Institute, and I believe we're the only Office of Drug User Health in the country, although there are very similar entities around the country. And this is our mission statement, looking at promoting harm reduction as a modality of working with people who use drugs throughout the state. And what I'm going to look at with some general comments around mental health and the impact of COVID is utilization of our syringe exchange programs, which is what our office oversees, looking at upstate New York as well as the city, and looking at the comparison between the two. But I will say that as we get into the piece about overdose, that the COVID impact, let me go back, COVID impact on people who use drugs has been really profound. We send a lot of messages pre-COVID that people shouldn't use alone. And then, of course, everyone is in isolation. What we saw a lot is, and a lot of this is anecdotal, is that people who had been in recovery and not using drugs began to use again. The drug markets has all changed. It's dangerous out there in terms of fentanyl in the heroin supply. So we were seeing a lot of people overdosing who were not connected to a lot of our programs, which is one of the issues, that somehow we have to resolve. But I'm going to look at syringe exchange programs just for a second. So what you see here is, you see Latinos, Latinx community, and white folks almost head and head in terms of utilization of syringe exchange programs throughout the state. And if you did, this is the whole state, but if you took it as just New York City, Latinx population would be the largest percentage of people utilizing the programs in New York City. Now, it can be slightly misleading. I think we should be really clear that a lot of people use syringe exchange programs, but up to 75% of them use it 4 times or less during a year. So that doesn't mean their needs aren't being met, but maybe maybe they're not being met if they're only there 4 times a year. But what you see is the 25% of the people who use syringe exchange on a regular basis use 77% of the services. And that's what we've always known, that if you're a frequent utilizer of a syringe exchange program, you really do use the services that they provide. And for those people that don't know, syringe exchange programs are multi-service agencies for people who use drugs. So it's not just syringes, it's a lot of case management, low threshold medical care, access to buprenorphine or referrals out to drug treatment, etc. And I should say, in terms of what happened during COVID, our syringe exchange programs were designated as essential services. And in that really bad period starting last March or so, when no one knew what was happening, all of the programs in the state delivered, kept going, served the population at great risk to themselves. And quite frankly, there was an heroic effort on the part of the syringe exchange programs. Even with that effort, several programs had to close during COVID due to the staff getting COVID. And so every so often, a few of the programs had to take breaks in terms of being able to provide services. So this is what you see in terms of infrequent participation. But then what's more disturbing in some ways is when we look at frequent participation, whereas Latinx community is very similar to the white community in terms of using a syringe exchange program, it drops quite dramatically when we look at frequent participation. And as I noted before, the people who use syringe exchange programs a lot get a lot of services. And there's reasons why this is the case. Some people don't inject all the time. Some people inject infrequently. Maybe they inject every so often. People have other sources of syringes that they use that they're more familiar with. Class and race-based health disparities in New York State are big barriers, we know. The whole premise of, it's just, what we've observed, and we observed it through COVID and who was impacted and who was affected. If you're walking through a neighborhood that is a high drug use neighborhood and you look like someone who's going to be targeted by law enforcement, that's a disincentive to using the program. And then you look at gender, and it's across the board in terms of women utilizing syringe exchange programs. only 20% of Latinx folks using student exchange programs are women, and it's a hard burden to worry about CPS and other issues related to family and childcare, which is often why women don't utilize syringe exchange programs. So I'm going to look at I'm going to qualify this. We receive information of when naloxone is administered by someone in the community. So the majority of naloxone that's distributed to people who use drugs or distributed throughout the state is done by the 25 syringe exchange programs in the state. They by far are the best trainers and distributors of naloxone to high need people. We don't have a really good mechanism for finding out when naloxone has been administered. So we receive, people go back to a syringe exchange program, they report that they've used this naloxone, which is the antidote to a heroin or opioid overdose, and then that information gets forwarded to us. So there's a lot of information here that we do not receive. So this is rest of state. I mean, this is the whole state. And you can see it's dominated by white people. That's the reports we get back. But when we move to the city, it's actually it begins to equalize out. And in terms of overdose deaths in the city, it's Latinx community folks and white people are fairly similar in terms of mortality. So I was actually quite relieved to see this, that we don't see a big disparity in, we see an appropriate use of naloxone here going to Latinx community. So that's actually kind of encouraging. As I say, this data is very incomplete in terms of accuracy, but it does give an indication of who is using naloxone, who's administering it, and who's reporting back. And we should remember that when we're talking about this kind of information, this is folks who use drugs, saving their lives, reviving people, their peers, and being responsive in a very haphazard and dangerous world of the contaminated drug market. And you see when you go to the rest of the state, Latinx and Black folk are completely underrepresented in terms of how much information you get back about when naloxone is administered. Given the nature of society in which we live in, and it's probably not that surprising. And I will stop there. And thank you very much.
Thank you very much, Allan, for sharing such important information on the use of drugs among our communities and also the use of naloxone. So the next presenter is going to be Dennis Romero. You're mute, Dennis.
Sorry about that.
Okay.
Great. Thank you very much. I'm happy to present here this afternoon. Let me see if I can do this. Okay, let me. Okay, can you see the presentation? Okay, great. So again, my name is Dennis Romero, and I serve as the SAMHSA Regional Administrator for the Substance Abuse and Mental Health Services Administration. I'm pleased to be here this afternoon to present on the impact of mental health and substance abuse from a national perspective. SAMHSA's mission is to reduce the impact of substance abuse and mental illness across America's communities. And we do this by reminding ourselves that we are the lead public health agency to advance the behavioral health of the nation. We do this by helping the states, territories, tribal nations, cities, and municipalities act on the knowledge that behavioral health is essential to health, that prevention works, that treatment is effective and people do recover. While mental health is a priority for us year round, during the month of May, coincidentally, we want to pay special attention to the importance of caring for our mental health and reducing the stigma that surrounds it. Let's look at mental health and addiction by the numbers. And this, I always find this to be very helpful. We know that, for example, that 75% of people with a psychological condition do not feel that others are understanding or compassionate about their illness. We know that 95% of people with substance use disorder don't believe they need help. We also know that 3 out of 5 people with a mental illness actually get treatment. Yet 1 in 9 people with a substance use disorder actually get treatment as well. And 1 in 25 US adults experience serious mental illness. The other piece of information that is also important to know is that 50% of all lifetime mental illness begins by the age of 14 and 75% by the age of 24. The CDC estimates that nearly 841,000 Americans have died from drug overdoses since 1999, making the modern addiction and overdose epidemic the worst in our nation's history. The COVID-19 pandemic has added new urgency to the search for solutions, with many communities facing higher rates of injury and deaths from drugs than ever before, and an estimated 88,000 lives lost to overdoses during the 12-month ending in August of 2020. The current Biden administration has made it clear that addressing the overdose and addiction epidemic is an urgent priority. When we think about mental health and substance use disorders, and we want to better understand why is it that we struggle so much from a policy standpoint and also from a treatment standpoint, I like to use the analogy or the picture of an iceberg. And this really suggests, gives a clearer picture as to why this issue is so difficult to wrap our arms around. We are all, as humans, pretty complex people. When it comes to mental health and substance use, like an iceberg, society only sees the behaviors, the manifestations, and the outward symptoms, that which is above the surface. What we don't see, or what everybody else doesn't see, are the drivers, the circumstances, or factors that foster or breed mental illness and/or addiction. Well, we have a lot going on as individuals. First of all, we have to remember that our health is more than just healthcare or genes. It's determined by a multitude of factors, most of which we are not attentive to. Our health is directly determined by the ability to afford, our ability to afford housing, childcare, supporting our youth, taking part in education and employment opportunities, being connected to our communities, and so on. As providers, your ability to work with health providers, housing entities, workforce entities, collaborate across sectors, share data and perspectives, and prioritize equitable approaches will have a direct impact on the outcome. As such, we have to be better positioned to address these inequities effectively and affordably, and elevate protective factors and reduce risk factors. If you are not familiar, I encourage you to brush up on topics such as addressing social determinants of care and health disparities, looking at adverse child experience or the ACE study, the ADA and Olmstead issues, MAPIA, and the Surgeon General report on facing addiction in America in 2016. These and many more issues are paramount in us to better understanding the impact of mental health and substance use. The list here is just a quick sample of the drivers that impact one's ability to develop one of these conditions. Now, when we look at what are the implications of COVID in the pandemic. First and foremost, disregard anyone. Do not pay attention to anyone who has the complete picture now, because the reality is that we do not have that full picture yet. The data is not in, not the complete data, at least. What the data is already telling us so far is that some people are developing behavioral health conditions not previously had due to isolation, quarantine, and other stressors. Those with behavioral health conditions, we're seeing an increase or worsening of their symptoms. We are seeing dramatic increases of approximately 900% in the calls to our disaster distress and other helplines. COVID-19 has directly impacted every facet of our lives. And as a result, we are seeing increases in such things as depression, anxiety, alcohol abuse and misuse. And frankly, that's because since liquor stores were considered essential services, they were open. And we saw a spike in the intoxication of alcohol. We're also seeing increases in marital and family discord, domestic violence, partner violence, overdoses and suicides, grief and loss. And the grief and loss in particular, the pandemic has significantly altered how families can memorialize deceased loved ones. And what are the cultural implications of that? And let's also pay attention to the provider community. Many of you who have experienced staff fatigue, moral injury, overwhelmed with cases, we are seeing emerging issues around social determinants of health and COVID-19 and the correlation between health inequities and vulnerable communities. And as a result, the toll of the pandemic is having on our health, behavioral health providers, and first responders is certainly a concern that I have today. And again, this is not the full picture yet. So this is a good, let this serve as a good model, as a good roadmap for the current direction that we're in. As I conclude my remarks, I want to pay attention to the reality that language matters. Rather than defining people primarily by their conditions or disabilities, people first language conveys actually respect and dignity by emphasizing the fact that people with disabilities are first and foremost just that, people. I love this quote. Bill White, who is the principal researcher on the origins of the recovery movement, once said, if you want to care for something, you call it a flower. But if you want to kill something, you call it a weed. And that, I think, speaks well for the behavioral health sector in general. Here are some resources that I think would be of value to know. Access to treatment, disaster helpline, or suicide prevention lifeline, or warm lines. I encourage you to leverage these resources. And this is my contact information. So please take advantage if you have any questions or that I can be of help to you. And thank you for the opportunity to speak this afternoon.
Thank you very much, Dennis, for your participation. And thank you to the three panelists today for participating in our session in Reunion Latina. So now we're going to go to the questions, section of the questions. So please, I ask the attendees to write your questions either in the chat box or in the question and answer box, and I will read them to the panelists. So there is a question for Oscar about, you mentioned that people use meth to engage to sexual activities, and it was a lot of indirections at the beginning of the pandemic, like social distancing, right? So when you use meth and you go to have sex with people, and you mentioned that there are groups of people, social distancing is definitely not being followed there. So does this affected the number of cases? Is there any data about MSM using meth getting more infected with COVID-19 or any correlation?
In order for that to happen, there has to be funding for studies on methamphetamines. And we're still living through what I believe will be 2 more years of all the attention at the federal level going towards opioids. So no, there hasn't been any of that information. But what we did is we interviewed about 25 young men who were actively using meth and engaging in sex during the height, in Texas at least, during the height of our COVID epidemic. And they were still hooking up, they were still using the apps. And all I had to do was look on my own phone at Grindr and Jacked and all the other ones. And people were still looking for sex partners. And it got so bad that we had to create a campaign, which is also available on our website at poderosos.org. And it was a campaign that was trans friendly, queer friendly, sex friendly, and sex positive. And it showed, for example, one young man, a cartoon figure, holding up a whole bunch of penis-shaped balloons and floating away. And the statement was, is this the right time to be looking to hook up? And don't let it carry you away. Some of the other ones showed people like, again, trying to have sex without like coughing or being near each other and how impossible that is. But we tried to be humorous, but to tackle the difficult subject. And they were very widely shared online because our community knew it was a problem. And sadly, as Latinos, especially one of the poorest regions in the country down on the border, we all live in multi-generational households. So whatever we were doing, wearing a mask while we worked at the grocery store, at a restaurant, or at an office, made absolutely no difference, because if we hooked up with a stranger at night, grandma was still going to get exposed to us, sometime during the next day. So that data is yet to be seen. And I would doubt seriously there'll ever be a study specific to whether people got exposed during a hookup or while being a waiter. But I would gather to think that a lot of the people that we lost, our grandparent wise, had to do with our MSM hookups.
Thank you for your answer, Oscar. So this question will be like for either Allan or Dennis or both. At the New York State and federal level, any initiatives to ensure we reach sensitively Spanish speakers?
What was any what?
At the New York State and federal level, are there any initiatives to ensure that we reach sensitively the Spanish speakers?
When you say sensitive to Spanish speakers, are you referring in terms of language?
The problems in substance use. That's a question that I found.
I'm sorry, I don't understand the question. Allan,
Yeah, I was just going to say I'm not aware of any targeted initiatives to any particular population, women, men, Latinx, Black. It tends to come out of SAMHSA or CDC to health departments or to community, and then distribute up that way in terms of how we use the money with our programs. So I would say no, but then I don't know everything.
Well, same here. I would say I don't know everything either, but I've heard that there's conversations similar to what happened during 9/11, that there's interest in doing some longitudinal studies on the effects, on the impact of the pandemic has had on our societies. And so there are a number of conversations currently. I don't know specifically if it would have any particular focus on a particular population or geographic area.
Thank you. I'm looking for questions that maybe in the chat. I don't find any questions. So I feel after this, please write your questions in the chat box or in the question and answer box so I can read them to the presenters and panelists. In the meantime, I would say if I have, you mentioned that we are still learning about what's happening, that we don't know yet the entire picture because this is still happening and we still collect data. But what would you say is the most important thing that we know up until now about substance abuse among Latinos or in general, in reference to COVID-19?
Is that to me?
Either one of you. Both of you.
Well, I will tell. I'll start. I'm happy to start. We know that the pandemic has had there's a clear correlation between the impact of COVID-19 and substance abuse and mental health. The data is very clear. We saw a spike starting in late April, early May, a spike in the suicides, for example. Some quick examples of some suicides that occurred in our region, which includes New York. We had some suicides, healthcare providers committed suicide. The most very well known one is one of the first ones was the one in New York City, a emergency room chair, female who hung herself at her parents' house in Virginia. We also know, for example, in Puerto Rico, we had a series of deaths, and it culminated, frankly, in late February of this year. The last week of February, we had 6 deaths. 3 of them were of people over the age of 50, and 2 were under the age of 50. And one of them was a female, and the rest were males. And all related to the overwhelming impact of the COVID and everything else that came with that, right? The loss of jobs or financial challenges, and the increase in the use of opioids. That has been big, as well as alcohol.
Allan?
Yeah, maybe I'll weigh in a little bit on that. And one of the things we know about, and this relates to COVID, sort of, I guess, directly and indirectly. But one of the things we observe in terms of who we reach post a non-fatal overdose is that very often they're not connected to any services. So I think social determinants of health really play a big role in who gets the most adversely affected, obviously, in terms of ill health and overdose. And COVID, as we know, really devastated communities of color in New York City. And what we would see with all the other things that are going on that we've talked about, that Dennis has raised and Oscar brought up, in terms of use, you're going to see a greater impact on the Latino community than perhaps the white community in terms of COVID. What we're seeing from preliminary data is that emergency department visits for people who have experienced an overdose, and you saw from the slides that people of color are underrepresented in upstate data in terms of who's reporting back on administering naloxone in the event of an overdose. You see an increase in Black folk and Latinx community going to emergency departments. So it's almost the flip side of what we see with the administration. So the administration is mostly white, but what we're seeing, and white people do go to the emergency departments for an overdose much more frequently than Latinx or Black folk. But what we've seen is this increase in Latinx and Black people going to an emergency department because of an overdose during COVID, and that was an unusual phenomenon.
Thank you, Allan. There's a question. I think it's directed to Oscar, but anyone of can provide any answer. Can the approach from organizations to sex and hookups during COVID lockups take hints from the harm reduction approach, like less stigmatization, focus on tools and strategies?
I'm having trouble with my internet. Every time the Border Patrol flies over my house, I lose it. And that's all the time. But you were saying, can you repeat that?
Is it possible that our organizations have some approach to sex and hookup during COVID-19 using a harm reduction approach?
Yes, what we have been suggesting to people is that they choose their 1 or 2 partners max, that that everybody get tested for COVID. And then if you're going to party and play, if you're going to bareback, you know, you still have an improved chance of not contracting COVID. And for that matter, you know, if people get tested for HIV and STIs and they stick to the same small group of people and encourage each other to get tested, you'll be in the same situation. But the reality is that if you look online, everybody says they've been vaccinated. And before vaccinations were available, everybody said they'd been tested for HIV and they were on PrEP. And the truth of the matter, as one of the people who work for the only ASO in the region, the only providers of PrEP, according to the internet, everybody was on PrEP. And yet I knew the numbers were closer to like 200 people, yet 2,000 people said they had it. So, you know, people will tell you what they need to tell you in order to get into your pants. We've all known that for years. You're beautiful. I don't have COVID, whatever.
Okay.
If I could just add to that, in terms of the increase in substance abuse and in particular opioids, we have recently started to encourage the conversation about the use of fentanyl test strips, for example, to help as a harm reduction strategy to help inform the users that maybe that what you're about to take may actually kill you. And if you know anything about fentanyl, fentanyl kills you. And so at least this is one way to begin to encourage some harm reduction strategies to reduce the overdose fatalities.
And that's something that still needs to be happening with meth users as well, because we're finding fentanyl being slipped into meth as well. Anything to encourage the addiction and all that.
Well, thank you. Many of our organizations provide HIV services, but not mental health or substance use. And we have seen the impact of mental health and increased substance use. So what we can do to integrate mental health and substance use services into our HIV services?
Let me preface my response by informing all of our audience and everyone on here today. You know, with the increase in the unaccompanied minors and asylum seekers earlier this year, SAMHSA was asked to help facilitate, help organize and address some of the behavioral health implications and substance abuse implications of these populations. And so I helped to create some work groups, national work groups to address this. And as a result, we today have now a whole range of fact sheets and webinars and TA to support organizations who may not know how to engage the Latino population, understand the cultural nuances of someone from Honduras versus someone from Argentina or someone from Peru, etc. Because just because you speak Spanish, that doesn't mean that you understand your same culture. One, secondarily, there are unique issues that many of these cultures bring and nuances. So we now have that. And as an aside point, our agency, we've started a new TA center called the National Hispanic and Latino Mental Health Technology Transfer Center. It's out of the School of Medicine, one of the schools of medicine in Puerto Rico. And I'm happy to send out some information about them. The director is Dr. Ibis Carrion, a wonderful lady who has been a passionate champion for mental health for the Hispanic community. And we also have out of New Mexico, we have a similar TA center that focuses on addiction and one on prevention, again, focusing on the Hispanic and Latino populations.
Thank you.
Oh, and by the way, one last thing, we have a website, we have a webpage too now, with all of the information that I just shared, and I can send that to you later and to be shared with everyone.
Definitely. Thank you very much. Allan, you want to
I wanted to say that if your executive director or your directors are telling you that they don't have funds for any of the mental health counseling that's needed by people who are, for example, partying and playing, using opioids or meth, call bullshit on that. Because if your organization is providing any kind of prep, that up until very recently, that money was flowing in by the bucket loads to be used as needed for other activities. Much of it didn't go towards prevention as it should have, and a lot of people misused it. But there's also money that the organizations bring in through their medical services and other programs that has flexibility to how it's used. And any program that has retention and care specialists for their trade positive clients, that has case managers, that has the linkage to care people, and numerous other programs, just because their job description doesn't say that they don't cover this subject, doesn't mean that you can't change the job description, add something to it, put them all through training, which is available free in most states, and add to how many people can help these folks when they encounter them, because it's not just a mental health counselor who can do this. And if you live in a city that has universities, approach the university by getting some of their interns to help you. You might get a new batch every semester, but don't give up, because there's ways to bring those programs into your organization.
Yeah, I would actually just follow on what Oscar just said. I think there's a lot that can be done by having a therapeutic relationship that can be quite short between providers and participants in programs. But I think what we've seen in response to opioids, for example, or actually, let me go back. So when we look at people who use drugs, we tend to silo a lot of the interventions that we get money for. So if you want disease prevention, it's syringe exchange to stop the spread of HIV and hepatitis C. Responding to overdose, it's buprenorphine or naloxone or other forms of opioid use disorder medications. And we tend not to look at people as in a holistic way. And, mental health care is, there's so much poor mental health in the population of people who use drugs that we don't receive discrete and targeted funding around mental health for the community of people who use drugs. We've touched upon suicide a little bit in here. Dennis brought it up. But there's an enormous amount of crossover between what we think of as an accidental drug overdose and suicide. There's a lot of people who reach a point where they're using, if they get really high, that is great. But if they also don't come around, that's okay too. There's kind of deaths of despair when there's people have sort of given up. And mental health care can help address that. In the same way as we can address that through, mental health care for people who are contemplating suicide. It's exactly the same for people using methamphetamine. There's very few, we don't have interventions like buprenorphine or naloxone for people using crystal meth. Mental health care is something that'd be really, really welcome in the community of people that serve people who use drugs, whether it's crystal meth, cocaine, opioids. I mean, people are using drugs because they work for them up to a certain point. They're addressing their early childhood trauma. They're addressing, old traumas that's come about because of their early childhood trauma, because trauma gets compounded by other traumas. And if we can provide some kind of level of support for people, we can undo a lot of the damage that both policies related to drugs have caused within communities. And we can begin to sort of rebuild communities, or help people recover from trauma and their drug use. And mental health care would be an important piece of that. And unfortunately, it's not something we get. it's not something we get. I'd love to have it for our programs in New York State. It's a really important but very missing component.
Can I also add that because, I mean, people don't set out often when they're on crystal meth to commit suicide, but you're very right in saying, Allan, that once they get to a certain point, if that happens, they may not care anymore. Because depression, especially during COVID, isolation, again, because of the COVID, not being able to see your support system, all of that has made things so much worse. And while opioids are not heavily used on the border, at least from here all the way to El Paso, meth is. And we've seen lots of overdoses from this, and we've seen deaths from this. And at a minimum, we need to train peer educators to do peer counseling if we don't have the professional resources available, because it may not be the best option, but it may be our only option. We just got funded for 3 years by Viv Pharmaceuticals to do a new intervention that we're going to test out and hopefully prove that it works for replication. But every 6 months, there'll be 12 more young men that'll graduate from the program. Those 12 men, we don't plan on losing. We plan to use them to recruit other men and to train them with other funding on how to do peer counseling and mentoring, so that not only can they bring people into the program, but when they're out in the community or partying, they can still, you know, support each other to not have somebody overdose, to not have someone opt to die.
Because that's very important, very important. Okay, we are running out of time. Just 1 more minute left. So I want to thank you, each one of you, for participating today and providing your knowledge in mental health and supporting Reunion Latina. Thank you everybody for attending today. And don't forget, please, to complete your day 2 online evaluation. You will receive an email with a link. And also to invite you to join us tomorrow on the 3rd day of Reunion Latina capacity building workshops that start at 1 p.m. So thank you very much, everybody, and have a good afternoon.
Thank you very much.
Thank you.
My poor voice, sorry.